Right, good morning, everyone, and welcome to session 2 of our RaCEEs course. It's good to see you today. Today's session is about key attributes of an economic evaluation. I'm going to co-run this session today with Luís Filipe from Lancaster University. You will remember Luís from our first session, so I won't need to introduce him today, but I just want to thank Luís for co-running this session with me. As usual, the session will be recorded, so we will make it available on the ARC Northwest Coast YouTube channel afterwards. And also the slides will be available to you afterwards, hopefully between today and tomorrow, everything will be there for you. But if you have any questions about the recording, of course, please let us know, as always. Right, let's crack on. Okay, so you will remember you had some homework after session 1, and the task from that homework was to identify a suitable economic evaluation for your team. Excuse me. Now, I just want to thank you for contributing to the homework, for helping identifying the homework, for helping voting for the best economic evaluation for your team. And now we are in the process of selecting the economic evaluation for team 2, but for the other teams, we now have an economic evaluation, and I'm going to show you the titles of the economic evaluations here now. So for team 1, the topic for team 1 is care for vulnerable children and families. The title is Faster Better, an economic evaluation of rapid and ultra-rapid genomic testing in critically ill infants and children. Team 2, as I was mentioning before, is still pending. People in Team 2 have the opportunity to vote until the end of today for their best economic evaluation. And I know people were on holiday probably last week, or with last week being half term, so you still got until the end of today to vote for your best paper. Andy, do you want to add something more?
No, not really. We've come down to three possibilities and just waiting for the final sets of votes to come in on those, and then we can decide which one's the best one to go forward. Thanks.
Great, thank you, Andy. Team 3, primary care. The title is Cost Effectiveness of School-Located Influenza Vaccination Programs for Elementary and Secondary School Children. And then Team 4, Social Care for Vulnerable Adults. The title is Cost Effectiveness of Nalmefene, or pronounce that correctly, for reduction of alcohol consumption in alcohol-dependent patients with high or very high drinking risk levels from a UK societal perspective. So these are the economic evaluations, and if you have a look at your team space after the session, you will see the PDF for your team economic evaluation, for your team article. So it's already there available for you. Of course, for team 2, the PDF will be available tomorrow, I think, after everybody has an opportunity to vote for the best economic evaluation. So I hope you're happy with the economic evaluation. Of course, it was a collective choice. We had to make some decision in terms of finding a suitable economic evaluation, but hopefully this is a collective choice, and you're happy with the economic evaluations here. And at the end of the day, we're using this economic evaluation to learn more about economics, health economics, to learn more how to critically appraise a paper. So we need to kind of see these papers as a vehicle to learn more, and that's our final ultimate objective. And hopefully these papers will be a good vehicle, will be something good to work on in the next few months. Before I crack on with the actual content of session 2, do you have any quick questions about the homework from session 1 you want to ask now? Okay, so I'll just move on, that's fine. Okay, this is the content of our RaCEEs course. Of course, today we're going to talk about the key attributes of an economic evaluation. As you can see, we are now entering the methods of the economic evaluation. So we are trying to talk about different elements, data that the authors of the economic evaluations used in terms of designing their own analysis and preparing their own analysis. So today we talk about the key elements of an economic evaluation. In the next session, which will be next Monday, we will talk about the cost data. Session 4 about the outcome data, and then session 5 we will talk about the results, the actual results from the paper a bit more. But just looking at the content gives us a good opportunity to start talking about the sections for our own commentary. So as you know, we will try to prepare a commentary that's the final output from our RaCEEs course. And if you are familiar with the scientific articles, you will know that articles are usually subdivided in different sections. Here you can see the sections we are trying to write, to include in our commentary. Typically, we will have an introduction, a method section, results section, and a commentary section. Now, the names might change, the headings might change depending on the specific requirements of the journals we are going to submit our commentary to, but yeah, we expect to have these 4 sections at the end. Now, the introduction is something that we actually will do towards the end of the course, so that we will try to write that up together after session 6. And just to give you a bit of context, in the introduction, we want to delineate why the economic evaluation is important, so why that specific paper was important, and how he added the additional knowledge to the evidence base. But we will talk about these a bit more after session 6. Today, instead, we are starting to concentrate on the methods. So in the methods section of our own commentary, we want to describe the key elements of economic evaluation, the cost data, and the outcome data. So we will use the information included by the authors in their own economic evaluation. We will extract that information and we will try to summarize it here. So, and in particular, we will try to make a good summary of these different elements that you can see here. And then this is something we will do between today's session and session 4. For the results part, for the results section, again, we are trying to summarize what the authors reported in terms of the main analysis and sensitivity analysis, and that's something we will do together after session 5. And then the commentary, which consists of 3 elements: critical appraisal of the economic evaluation, implication for policy and practice, and recommendation for future research. If you are familiar with the RaCEEs program, you will probably have seen these different subsections already. So this is something we are going to concentrate on at the workshop and also after the workshop. So nothing to worry about for now. Okay, overview of today's session is to understand and describe the key elements, the key attributes of an economic evaluation. In particular, we will look at the interventions being compared, including the population and the location or the setting. So that's the first element we will look at. And then we will look more in depth about the analysis, so the analytical approach actually of the authors, the types of economic evaluation used in the study, the sample size, the perspective, the time horizon, and then Luís will talk about the modeling techniques later on. Okay, as you know, in an economic evaluation, we typically compare 2 or more interventions. So you will have a new intervention, which might be a new drug, a new medication, new therapy, for example, a new type of surgery, or a new treatment more generically. And that is compared with usual care. That's typically the comparator people use in an economic evaluation. Might be something else as well. But there might be more than 2 interventions that are compared, so that we need to be aware that there might be multiple interventions there that the authors decided to compare. But hopefully in our economic evaluations, there will be a simple comparison or a simple enough comparison between 2 or maybe 3 interventions. Now, what we're trying to do with our commentary is to summarize the characteristics of the interventions being compared by the authors of the economic evaluation. So what are the key information we need to extract from the paper? First of all, we need to understand and extract information about the population. So that could be quite clear by looking at the title, for example, by looking at the aim of the study. We want to know what what kind of population is going to be targeted by the intervention. For example, might be intervention for people with diabetes, cancer, dementia, or people with some kind of disorders. So we just want to know the type of the disease or condition affecting that specific population. Or there might be no disease or condition, might be generically a population, for example, young people or elderly people, something like that. So it doesn't have necessarily to be somebody with a specific problem or clinical problem. In terms of the type of intervention, so usually you have different intervention being compared. They might be all medications. They might be different intervention like psychological intervention. So we need to be aware of the variety of intervention that might be compared. If, for example, if you think about treatment for depressions, you might be having a comparison between pharmacological intervention versus psychological interventions, right? So it's important to be able to identify what type of interventions the authors are trying to compare, and also how they work. Now here I try to list some examples of the type of interventions you might see in a paper. For example, if you see a drug, we need to be able to understand, for example, how the drug works in terms of administration, frequency, dosage. Same for therapy, the number and type of sessions, who delivers the therapy or who receives them. If we are dealing with a diagnostic tool, the characteristic of the scans or the tests which are used to detect a particular condition or particular disease. And this is not an exhaustive list, it's just to give you some example of the type of information we need to extract from the paper, basically. Location and setting, again, very simply, we are trying to identify where the interventions took place, both in geographical terms, but also in terms of the type of settings, clinical, social care settings where the intervention took place. Any questions so far? Okay. I'll just move on, if I'm able to move on. Here we go, yeah. So just to give an example, how to extract these characteristics of the intervention from a paper. I mentioned before that you can probably find the information about the population in the title already, but it should be really clearly outlined within the aim of the study. And you will be able to see the aim of the study in one of the last paragraphs of the introduction, typically. I will use this word a lot, typically or usually, because that's really, in my experience, probably other people's experience, where you will be able to find these different elements in a scientific paper. But that's not always the case, but usually that's the case, okay? In terms of the type of interventions and how they work, again, this is something that you can find in the method or in the methodological section of a paper. There could be a section called interventions or comparators, something similar, but not always. That again depends on the specific requirements of the journals. And again, information about location and setting could be described within the A-level study, but you can typically find that also in the methods. Now, I'm going to show you an example here of how we extracted these elements, the information about these elements in a previous RaCEE that Luís and I co-produced with the help of a couple of clinicians last year, I think, if I remember well. So this is an article, an economic evaluation, which was produced in 2022 and was related to the use of a particular gel for people with advanced Parkinson's disease. You will have access to this paper and to the RaCEE we co-produce in your team space. So there is a folder there with the PDF for the article in the RaCEE. Now, I'm just going to show you what kind of information we went to extract within the paper. So if you look at that paper, if you look at the PDF, at the end of the introduction, there was this sentence about the aim of the study. So in particular, we were able to identify the population, so patients with advanced Parkinson's disease. That's as easy as that. And also the type of intervention. So highlighted in orange here, you can see the characteristics of the intervention. So we had this particular gel, which was compared to standard of care. And then in this other section, within the methodological section, you can also find some information about standard of care. So that's the kind of information we were looking for. And location, of course, is highlighted here in pink, which was England. As I mentioned, you can find this paper, you can find the RaCEE in this folder in your team space. The folder is called Example Previous RaCEE. And here you can see the actual text we wrote up in our RaCEE. So this is the text we try to, we wrote up to synthesize, to summarize what the authors did in their economic evaluation. We try to provide information about the interventions, the population, and the location. Just to give you an idea on how to write up the characteristic of the intervention. Now, this is not, the only way we could possibly write up the characteristic of intervention, but of course there might be multiple ways. But this is, in our opinion, probably a good example now to write up the characteristics of the intervention in a very concise way. So you got information about population, type of intervention, and location. Do you have any questions before I move to the other elements of an economic evaluation? Just check the chat as well. Okay. So I'm now going to talk about the types of economic evaluation used in the study, and then I'll talk about the sample, the perspective, and the time horizon, and then Luís will talk more about the modeling techniques. Now, let's start with types of economic evaluation. As you probably know by now, economic evaluation is an umbrella term which groups together different types of economic evaluations. I'm going to describe these types one by one here in this slide, just to give you a bit of context. What is important to remember, though, is that these are not mutually exclusive. So you might find different types of economic evaluation within the same paper. So just because you see one type, that doesn't mean the author used only that type. They might have used also some other types of economic evaluation within the study. Now, let's start with the simplest type, which is the cost and minimization analysis. It's a very rare, I will say, type of economic evaluation. As you know, in economic evaluation, we try to compare cost and consequences, or cost and outcomes, let's say. In this particular type of economic evaluation, the authors only consider the cost side. So they don't consider the outcome side, because the interventions are assumed to be equally effective. So for example, if you look at the last column, the authors wanted to compare the cost of administering a therapy to treat hypertension using two alternative modes of delivery, which are assumed to be equally effective. And these modes of delivery were A, in the hospital outpatient setting, or versus B, in the private homes by involving community health staff. So they're just comparing the cost of these two modes of delivery. This assumption around the intervention being equally effective is often wrong, is often not really realistic. So that's why cost minimization analysis is not really that used in common practice. The second type of economic evaluation I wanted to talk about is a cost consequences analysis, where we are trying to consider here the cost and the outcome side together. But the outcome side is considered in a disaggregated format, or in a disaggregated way. What I mean by that? So if you look at the last column again, we can see that given that the assumption of equal effectiveness might not hold, we are now trying to compare alternatives A and B in terms of cost, but also in terms of consequences. So the outcomes might be different across the two interventions. And we're trying to list things like acceptability of the intervention on the part of the patients, but also on the part of the health or social care professionals, willingness to use the intervention, resource use, health, clinical outcomes, and so on. All these outcomes are listed in a separate way. Again, cost consequences analysis is more common than cost minimization analysis, but not very common. Instead, cost effectiveness analysis is a very, very common type of economic evaluation. Again, we are considering cost and outcomes, but in terms of the outcomes, we are considering a single effect of interest, which is common to both alternatives. Let's have a look at the example. we are comparing alternatives A and B in terms of cost and a single effect of interest, which is measured by a reduction in blood pressure. So in this area, which is hypertension, we are trying to identify whether the interventions were differing in terms of a reduction in blood pressure, which is very relevant for people with hypertension. So that's the single effect of interest we are trying to focus on here. And implicitly, the outcome of the cost effectiveness analysis will be cost per reduction in blood pressure, for a point reduction in blood pressure, for example. Another very common type of economic evaluation is a cost utility analysis. So again, you might have heard this before. Again, we are comparing cost and outcomes. But here we have an outcome which is more generic. So we're not talking really about a specific or condition-specific clinical outcome. We are talking about healthy years, which is an outcome measure which accounts for both quality and quantity of life, and is typically measured by the quality adjusted life years, or QALYs, which I'm sure many of you have heard of before. So in terms of the example, we are comparing alternatives A and B in terms of cost and a single composite outcome, which is the healthy years, or quality adjusted life years. And we're trying to estimate the quality of life changes and the life expectancy, or the survival of hypertensive patients being treated. So it's a generic outcome measure, but just because it's generic, it doesn't mean it's not that great, because if it's generic, it means it can be applied to different areas, to different diseases. And QALYs, as you know, you probably have heard in the past, can be applied to different condition, to different diseases. So that's kind of one of the advantages of using a cost utility analysis. Finally, another quite common economic evaluation is the cost benefit analysis, where instead we are trying to monetize everything. So not only the cost, which of course would be natural probably to monetize cost, but also we're trying to monetize the outcomes. For example, we might try to give a monetary value to a person's life, which might sound not morally acceptable, but that's something we can possibly do. But in terms of our example, we can estimate how much the patient will be willing to pay for the therapy. So we're trying to assign a value to the therapy, okay, whether they value more one type of therapy versus the other. But the two most common economic evaluation, I would say, they are the cost effectiveness analysis and cost utility analysis. How to extract information about the type of economic evaluation? The first thing I would say, do not jump to conclusion. What I mean with that. Now, if you open your article later on, if you open the PDF of your article, you will probably see the term cost effectiveness a lot throughout the article. But just because it's mentioned a lot, it doesn't necessarily mean the authors conducted a cost effectiveness analysis. Cost effectiveness is usually used as an umbrella term, and is often abused, I would say. Instead, try to look at the outcome measure used by the authors. So, for example, if they use, for example, cost per gain in 1 point reduction in blood pressure, that's a specific clinical outcome. So you know they're dealing with a cost effectiveness analysis. If you see a cost per additional healthy year or per additional QALY, they are dealing with they're performing a cost utility analysis, or CUA. Okay, so a way to determine which types of economic evaluation the authors have used is to look at the outcome measures. For example, in the article I was mentioning before, there was a specific sentence which detailed the type of outcome measures used by the authors. So they used life years, which means they conducted a cost effectiveness analysis, and the quality adjusted life years, or QALYs, which means they conducted a cost utility analysis. And as I mentioned a few minutes ago, they are not mutually exclusive. You can run more than one type of economic evaluations. Any questions? Just checking the chat. Oh, Maria, yes.
Sorry, I was trying to find the raised hand reaction. I've just one question specifically for the difference between cost utility and cost benefit. So I might understood it wrong, but is cost benefit just an extra step to cost utility where you monetize each quality, let's say?
I actually don't know whether you can monetize quality. Maybe if the other team leads might want to jump in, please feel free to do so.
I guess you can. No, you can.
Yeah, probably.
You can compute the willingness to pay for an additional quality.
Yeah. Okay.
Then you may have to debate how precise it is, because it is always going to be through surveys or maybe discrete choice experiments. You will need to do some type of methodology to try to infer the willingness to pay of that people have for an additional quality. But yes, technically you can compute the willingness to pay. So that well, not for a quality, but for instance, for one life year, you have the time trade-off method, right? Where you ask people, do you prefer to live with this disease for some years, or how many years are you willing to pay to get cured? You can put some monetary values in there and get a willingness to pay. So sure, you can. So in a way, yes, but sometimes you will just so not necessarily get the benefits for a quality, but for instance, the willingness to pay for a certain service or drug. Imagine that you have a new drug and you can compute, like I said, discrete choice experiment. It's a little bit technical, but basically you can infer how much people would be willing to pay for a certain drug, and you use that willingness to pay as your benefit part, and then because it's in monetary values, you are going to have a cost benefit analysis.
Right. So the main difference between cost utility and cost benefit would be the information about willingness to pay.
Yes. Yeah, just to monetize that benefit, I guess. Sorry, Luis.
Not necessarily willingness to pay, but most of the times it will be because some things are really hard to monetize. Most of the benefits are really hard to monetize. If I ask you, imagine that you live in a place with a factory that is polluting your region. How will I infer the value, the monetary value of taking out that factory? Probably I need to ask people around, how much would you be willing to pay to get rid of that factory and get your region with clean air and no pollution at all? So yeah, most of the times it is going to be based on willingness to pay, because it's really hard to infer the value of something. But sometimes you have some quasi-experimental methodology that allows you to do that without asking people, just based on people's choices and behaviors. One example would be, for instance, houses. You know that houses that are facing south are more expensive. You know that houses near green places are more expensive. And people don't tell you that. You just know that because you see that people are paying more for those houses. Sometimes you can infer that from quasi-experimental methods, just observing what people do. But yeah, it's tricky.
Yeah, makes sense. So when you have, one more question. When you have the NICE threshold, is that considered a willingness to pay?
Yes, that's what let's say the healthcare system or the society as a whole is willing to pay for that additional quality. Yes, that's
that
we
makes
will
sense.
talk a bit more about that, I think, in session 4.
Yeah. So I was just trying to understand the difference between the two. Thank you.
That's all right, and thank you, Luis. Okay, any other questions? Okay, I'll move on then. Okay, I'll talk briefly about other elements of the analytical approach. I'll take these elements all together because I think they're quite straightforward. So we talk about the sample, the perspective, and the time horizon. The key information we need to include about the sample is the type of participants involved and the size of the sample. So again, the sample differs a bit from the population. The population is, for example, people with stroke, dementia, and so on. In the sample, we might have some additional inclusion criteria we need to consider. So, for example, people with stroke which might have mild cognitive issues. for example, or young people attending specific schools, maybe high school or primary school. So you got some more information about the type of participants involved in the study. The size of the sample, quite straightforward, is going to be a number of people included in the analysis. The perspective is an element which is really characteristic of an economic evaluation. With perspective, we mean the range of costs and outcomes taken into account. So you could, for example, consider the costs incurred by the patients in attending specific sessions, maybe travel costs, for example, and the outcomes, of course, attached to attending the specific therapy session. Or you can consider a cost also incurred by the families, the caregivers, or more generally, the cost for the health and social care system. So, for example, the cost for 10 minutes of consultation with your GP, the cost of a specific type of equipment, and so on. Or even more widely, we can consider the costs and outcomes for society as a whole. So if a person is ill, it might be likely that they can't go to work. In that sense, it would be productivity costs for the employer, or even recruitment costs that the employer will have to incur in order to replace that person for a period of time. So the perspective is really important, and it gives you a sense of what kind of costs and outcomes the authors have considered in their economic evaluation. Time horizon. Time horizon is really the time scale of the analysis, which might be short-term. So it might be, for example, just within the study period of a randomized controlled trial. So if the economic evaluation is run alongside a randomized controlled trial, there might be a very short-term period of analysis, like 6 months, 1 year, or 2 years, or longer term. And usually it's better to extend the analysis to the long term, like the lifetime of the individual, so multiple years, for example, 10 or 20 years into the life of the individuals. How to extract this information from a paper? Now, the sample, you will usually find information about the sample in the methods, and the sample size is usually included at the beginning of the results section. For the perspective, is typically outlined in the method, but could be also within the aim of the study in the introduction. And the time horizon, again, it should be included in the method section. A very unorthodox tip here is if you struggle, try Control F. So if you have your PDF, search for the specific word. For example, if you search for perspective in your paper, you might be able to find directly and very quickly the information about the perspective. The same for time horizon. Okay, so if you struggle, I tend to use that this technique to find very quickly information about the perspective and time horizon, or even the sample in some cases. Let's go back to the article we use as an example. So the article around advanced Parkinson's disease. So in the introduction, this is the sentence we were looking at before. We already know this perspective, which is the perspective of NHS England and Personal and Social Service. So you got information about the perspective there. We also found information about the sample within the methodological section. So we have information about the characteristics of the participants in the study and also the sample size. And again, within the methodological section, we also found some information about the time horizon. Here is a quite long time horizon of 20 years. And here is how we extracted this information, and how we reported this information in our commentary. So we try to summarize the type of economic evaluation, the sample, and the time horizon. Again, I'm not going to read it now, but you got access to the paper in your team space. Okay. Do you have any questions before we move to Luís' part? Hilary, yeah.
Yeah, I'm not quite sure how to frame the question, really. It's about the slide that you showed about the sample perspective and time horizon, and the cost of that. are the costs in that perspective entirely monetary, or are they, if you like, personal costs to the patient or their families?
There should be, we will talk about cost a bit more in the next session, actually, but there should be two components to the cost. One is the how much you actually use of your time, for example, or the healthcare professional time, or how much your family or the patient family use in terms of their own time. So that could be, for example, if I need to take, let's say, somebody in my family to an appointment, I might use 1 hour of my time. Okay, that's the natural unit of my time, and then there should be another component which I can use to monetize that that time. So 1 hour of my time is, for example, I don't know, could be 20, 30, 40, I don't know, something like that. And you try to monetize the value of that time you spend in order to take a member of your family to an appointment. And the same for the GP. I mean, 10 minutes of the GP will be more, we will be able to monetize that. Okay. So,
right. Thank you. That's good. And one sort of bit of follow up on that then is there a means of analysing the more social and emotional costs?
Oh, okay. I'm sure there is. Yeah, that's a question which like borders on the intangible a bit. Yeah, that's something is very interesting. I'm sure there is a way to
maybe the health psychologists could answer that for us.
Now, to give you an example, we did a review some years ago about digital health intervention, and for example, economic evaluation usually concentrate on qualis, which is good, but there are other elements that, for example, when you deal with the digital health interventions, which are quite intangible, for example, how you accept the use of a app, whether, it might frustrate you using a specific app or specific technology, and that frustration, is important to consider, and whether you're able to quantify that frustration, monetize it, could be really challenging. But the same for the healthcare professional dealing with new equipment, new technology. There might be a training cost involved, which probably is easy to identify and to monetize, but there are also some emotion which can be more difficult to quantify. And the same for the caregivers. Caregivers is another side which hopefully is being recognized more and more. So the cost attached to the caregiver's time, emotions, and so on is something that is being recognized in economic evaluation more and more.
That's great. Thank you very much for your answers. Thanks.
Right. Okay, I'll stop sharing now.
So
and
let me just say something while I share my screen as well, which is yes, a lot of things are still not monetized in an economic evaluation. That's for sure. But one thing that I want to say is that sometimes they can appear in the benefits. So for instance, we are talking about the caregivers, the time of the caregivers and so on. Sometimes you may be able to compute the quality of life also for the caregivers. So you can include them in there. So imagine that a certain intervention creates a loss in terms of quality of life for the caregivers. You can identify that, or the opposite, creates a better quality of life for the caregivers. You can identify that, but definitely there's a lot of things that still don't appear in economic evaluations. Most likely because they are very hard to measure, but I think the way forward is to try to measure those and try to include them as well.
Thank you, because it strikes me that there may be long-term economic costs to the emotional and social effects on, say, for example, the caregivers later on, which actually translates into the effects on their health, which become that impact the actual monetary cost as well, or if you're looking at something much longer term and broader. So yeah, thanks very much.
Not a problem. So can you all see the slides?
Yeah.
Okay, so let's continue then. Now, I'm going to talk a little bit on how to model an economic evaluation, and it can be a little bit tricky. So sometimes it's super straightforward. Sometimes imagine that you are just, for instance, I'll give you an example of something that I'm kind of doing. I will do still. It's still in the beginning, but we have some technology that we want to evaluate. It's a technology about giving medication to people, usually people with some type of cognitive impairments. So it's a technology where there are alarms that tell if people took the medication or not, and the alarm, the alarm team, I guess, it will call the person in case they didn't, and so on. And the idea is that with those technologies, we will be able to save time on the caregivers part, the professional caregivers or the informal caregivers that usually need to go there and help the person getting the medication. So in this case, it's very straightforward because we want only to do it within the trial. So we just want to compute the time saved in terms of the caregiver's time, being it informal or formal. And then we want to compute the costs. We have the intervention. We compare it against the standard of care. And we just compute the differences and we get our ICER, our incremental cost effectiveness ratio. So just the number of hours saved divided by the extra cost, and that's it. So super straightforward. I think if you have any doubts, please stop and ask me, but that one should be super straightforward. Now, sometimes things can get a little bit more trickier because sometimes a certain disease intervention, the response of people to the intervention can have very different pathways, very different states, and those need to be modeled. So when you have a certain case where you can identify a lot of different states of, let's say, a disease, for example, you are going to use decision trees, and that's what you will see in economic evaluations. Now, when you have those complex diseases with several different states, but you want to do not within trial, you want to do something that you want to extrapolate through time. You want to, for instance, evaluate it through the lifetime of an individual, let's say for the next 20 years, then you will need to use another model, which is a Markov model, which it's basically a decision tree that you extrapolate throughout the years. And then finally, Markov models have some limitations. Sometimes they will not, if the processes are too complex. If, for instance, this is a little bit technical, but if you need a little bit of memory, you need to understand that some people went through something and now they have different probabilities of something. You use discrete event simulations, okay? I'll tell you a little bit more about each one of them just in the next slides, but those are the three types of things you are probably going to find in economic evaluations, either a decision tree, a Markov model, or a discrete event simulation. Of course, if it is just a simple outcome within trial evaluation, maybe you won't find any of those because the ICER will be very straightforward and will come directly from the experimental method, which can be an RCT, a randomized controlled trial, or from some quasi-experimental method. So, okay, let's go with the decision tree. So this is a decision tree. And this one, I chose just a basic one. This is just an example. It's not even a real one, just for you to see. Don't get scared about the letters in there. You will see that this is very, very, very intuitive. So in this case, you can see that you basically have two treatments. You have treatment X above, so here, and you have treatment Y below. So that's it. You need to choose between treatment X and Y. Now, you have that treated for each one of them, the outcome can be that the person gets cured or the person doesn't get cured, because we know that in health, there's a lot of uncertainty. There's a lot of uncertainty around drugs and treatments and so on. So you can see the same for treatment Y. The person can get cured or not, okay? And then for each of these pathways, so let's say treatment X cured, you'll have some outcomes. So you will have the expected life years, for example. So if the person is cured, the person is expected to live a certain amount of years more. And of course, you have the cost, which is not yet the scope of this class, this session. But yeah, so you will have both. You have both for this one, the benefits, the outcome, so yeah, the benefits and the costs. Now, the same if you go with treatment X, no cure, again, you'll have the life years, you will have the costs. Now, you will see that we have here PX and 1 minus PX. These are just the probabilities. So treatment X will have a certain probability of curing that person. And if the person is cured, that person will live a certain amount of years. So it will also have a certain probability of not curing the person, and then that will have a certain amount of years at a certain cost for that person. Now, the same for treatment Y is exactly the same, the probability of a cure with some results, and the probability of no cure with certain results. Okay, this is just PX, 1 minus PX, and so on. Let's forget this. Let's see exactly how this would look like if we substitute it with numbers, okay? And again, feel free to interrupt me. You don't even need to raise your hand, just unmute yourself and interrupt me. But that would be this. So treatment X, you can see that it has a 75% probability of curing the person. And if the person is cured, that person will live another 30 years. Now, the treatment X has a probability of not curing the person, which is 25%. And in that case, the person will live 20 years. Okay. Then again, it's not about the cost, but you can see that you also have the costs for each node of these three below the years. Now, treatment Y. Treatment Y has a probability of curing of 90%. So it's better than treatment X. And again, it's the same thing. If the person is cured, the person lives for 30 years. It's just the same state in that sense. It's just a different probability. And then if the person doesn't get cured, with a probability of 10% and lives for 20 years. Okay. Of course, again, this is not about the cost, but of course, this one you will see that it is more expensive than treatment X. Otherwise, there would be no choice to be made, because if treatment Y is both has a higher probability of curing and would be less expensive, then of course it would dominate treatment X and you don't even need to do any computations. But it's not the case. So it's more effective for sure, but also more expensive. Now you can do the following. You can pick these probabilities, and you can literally compute the expected benefits, which in this case are in terms of life years of each treatment. So in this very, very simple case, they are very easy to compute. Usually I would say decision trees are easy to compute, even if they get a little bit bigger. But it is just to compute the expected value, which is, you know that with a 75% chance for treatment X, the person will live 30 years. So you literally multiply 75% times 30 years, and that gives you the expected value of that person. And of course, I'm forgetting the second part. So no cure with the 25% probability, you multiply by 20 years, which is the second case, and you get the expected life years that someone should expect to live with treatment X, of course, on average. Okay, you can do the same for treatment Y. In treatment Y, you know that the average person will live 30 years with a 90% probability, so 90 times 30 years, plus the other possibility, the other node, is that the person is going to live only 20 years with a 10% probability, which is the case of not being cured. So you have this 10% times 20 years. And you will see that for treatment X, you got the computation gives you 27.5 years. For treatment Y, you get 29 years of expected life for the average person. Okay, Any questions? So it's a little bit mathematical, but I hope it's still understandable. Now I have here for you as an optional homework, you can do the same for the costs, and you can compute the ICER. So Valerio already explained you in in previous sessions how you compute an ICER. So it's the difference between these two divided by the difference between costs, or the opposite, the difference between costs divided by the difference between these two. So you can just compute, it's going to be exactly the same, 75% times the cost of the first node plus 25% times the cost of the other node, and then you compute the ICER. But try to do it at home. It should not be too difficult. If you have any trouble, please ask us for help. So, and yeah, this is a decision tree. Now it can get, I don't have an example here, but it can get a lot more complicated because you can have cure, no cure, but you can have things in between. So you get cured, but you get some issues, or you don't get cured, but you stay in some condition, or you don't get cured and you die. So there's several stuff that you can add here that can make these nodes become a lot more complicated. Now, let's go to the second one, which is the Markov model. And the Markov model, the truth is, it is just a decision tree that is repeated several times. Because sometimes you do, let's say, a randomized control trial, you find something within a year or two, you find that some treatment, in fact, produces some benefits within 1 year or two. But you also know that there will be differences across time. Across time, people will behave differently with one and the other treatment, and you want to compute the life expectancy, for example, as we were doing there, across time. And you know that in 2 years, for instance, people are less likely to die, even if they are sick. For most diseases, they will not die that immediately. So whenever you give them a treatment, maybe one treatment will delay people dying for 5 years. The other treatment will delay people dying for 10 years. So sometimes you need that time horizon to be able to compare to alternative interventions or treatments. And that's why you may want to use a Markov model. Now, you'll see that this is basically a decision tree. I have another example in here in which is people can be in 3 states. So they can be asymptomatic. Well, 4 states, they can be well, having nothing. Then they may become sick, but be asymptomatic. Then from asymptomatic, they can progress through another state, which is they can die. Either from natural causes or from the disease. Well, I would say asymptomatic, probably from natural causes. But then they can stay the same. They can stay as asymptomatic, or they can move to progressive state. And this would be basically a decision tree again, where you have people, they are well, and then they can go to asymptomatic, they can go to dead, or they can go to progressive. Now, if they are in progressive, they can stay in progressive, or they can die. Again, this could be another node of the decision tree where they are in progressive and they continue to either stay the same or die. Sometimes Markov models will allow you to go back. For instance, go to progressive to asymptomatic. But yeah, that's it. And the thing that you want to do in the Markov model, usually you want to, through randomized control trials, you want to get the probabilities of people transitioning between states, much like we had in here. You want to know the probabilities of people being in one or another. I'm just aware of time. How much time do I have, Valerio? Probably not that much.
Probably not a couple of minutes. And then,
okay,
I'm
still far away, but let me then try to explain this very fast. So, okay, this is basically a Markov model, the visualization, where you start, you are fine, and then you have a group of people, and people start progressing through the states. So they can go to asymptomatic, they can go to progressive, or they can die. So you will see that in cycle 0, everyone is fine. Then in cycle 8, for instance, you already have these people here as asymptomatic. You have these people here as progressive and these people here as dead. And then as you move on in the cycles, the tendency is that people are going to die either because of the disease or because of natural causes. So that is called the absorbing state most of the times. And you will see that less people will be well, less people will be asymptomatic, less people will be progressive, and more people will be dead. And through this, you can basically do a table where A is being well, B is being asymptomatic, C is being progressive, and D is being dead. And you can basically run a model where people do what you are seeing in this figure. They start here, one is basically 100%, and everyone is in A, and then they start moving. So less people are in A, more people now are in B and C and D. So they start moving, and you will see that A is going to be reduced across here. So this is each year. So less people are without a disease, and more people will be in asymptomatic, progressive, and dead, and they will move. Now, for each year, you can literally compute the amount of life years that exist in that year. You can sum all of the years, and you can compute the total that is here below, the total number of life years expected from a certain intervention. So imagine that this is intervention X, like before. You will have that with intervention X, you expect this pathway, and we'll expect this number of life years with gained with that intervention. Now you can do that for intervention Y in the other example, for example, and you will get the amount of years with that intervention. Then you can make the difference between the two in order to try to infer the difference in terms of benefits. Of course, you can do the same about the costs. You compute the difference in the costs, and then you compute your ICER. So this is the idea. Now, I'm probably going to skip this because I don't have any more time, but this is just an example from the paper that we analyzed, the one of Chowdhury, where it's basically a Markov model, and you can see that it is a lot more complex than what I just showed to you, because you had 5 levels of disease, which is given by this HY code, but then within each type, which level of the disease, you would have also some levels of off time. And you can see how complicated this can get. But this is the idea, is that people, like in this figure, they transition between states, and you can compute for each state, for each year, how many people are in each state and how much you gain in terms of benefits, which can be, for instance, the amount of life years gained. Now, finally, and I'm going to almost skip this, we have the discrete event simulation models, which are basically when Markov models are not enough, because you need the procedures are a lot more complex. You need the model to recall which people was in each state, because the probabilities are going to change based on that. An example that I can give you is, imagine that we are talking about cancer. And someone is fine, then that person gets cancer, that person gets cured. But after that person getting cured, we know that people who, I guess we know, and correct me if I'm wrong, but people who had cancer before have a higher chance of getting cancer again. So you need to change the probability. So you need the model to remember that that person already got cancer. So sometimes you can do that in a Markov model by adding some more states, but most of the times when things start getting complicated, you go for a discrete event simulation. And here you can see basically very fast that it is really a lot more complex, where you have this person entering in having a PTA, which is the percutaneous transluminal angioplasty, or the intervention that they are measuring, and then you can have several things happening. People within the 30 days outcome, people die, or they die from general mortality or from the intervention. Then they can stay alive and patent, or they can have an acute failure. Then within the acute failure, you have again general mortality, and then a lot of other things that can happen. Within alive and patent, again, general mortality of other things that can happen. you can see that it's really tricky. They get good. They may have late failure and go here, or they may have develop contralateral symptoms and they have to get a reintervention, which can be a PTA or bypass, or can be an amputation. So just for you to see that it's really tricky, but it's the evolution of the Markov model when the procedures are really complex and you want to go for something else. So now, just showing you how we did in our commentary to find basically the Markov model within the text and what do they say about that. So on the left, you have our comment. On the right, you have the paper. Basically, in the paper, we went to, it's in the methodology section in a subsection called model structure. And you can clearly see that the first thing they say in the model structure is that they use a Markov model. And then they continue, and in the next page they say that the model is redistributes the population into 25 combinations, and they explain the 25 combinations where you have these 1 to 5 HI scores. I don't remember what HI stands for. If Valerio remembers, they can say. And then you also have 5 levels of off states. So they say that very clearly, and then we basically just rewrote this in our words in the methodology section. So, okay, you can see again, type of economic evaluation, Markov, the health states, so it's here, in fact, HOAN and DR stages, the 5 ones, and then the off times. You can see here, type of economic evaluation and the health states. So, okay. We are done with this class. Sorry that I was a little bit fast, but also over the time in this part.
Well, thank you, Luís.
Yeah.
So,
do you want to go?
I'll go through the homework very quickly. I'm sorry we're running out of time a bit, but just to give you the indication for the homework. So you just have one task, and it's to fill a table with the info on the key attributes for economic evaluation. And we're going to ask you to complete this task by next Monday, the 10th of June. So if you go to the next slide, Luís. Here where you can find the document, the table, so you can access the folder on session 2. Then next slide. You will see a document with your name on it. So you will be able to open that document. And then next slide, there's the table. In this table, you need to try to fill in the last column, which is attribute info. And in the previous columns, you got information about the attribute, the definition, and where you can usually find this info within the paper. So try to do as best as you can. We are not here to judge you. You try to extract as much information as you can from the paper and report it in the last column. If you struggle, please get back to us. Please ask us questions, and we will check the tables, and we can work with you in order to find the correct information. But it's a good exercise in order to familiarize yourself with all these attributes. It is important to know that you don't need to memorize everything we said in this session. You're not going to run an economic evaluation tomorrow. It's just to be able to understand what different terms mean. So you can go back to the slides and refresh your memory in case, and then try to fill in the table. Next slide, yeah. And that's it for today. And sorry, we are 7 minutes late, but if you have any questions about the homework, anything we discussed today, feel free to get back to us. And then we will see you on next Monday, the 10th of June, for the session on costs. And if you have any questions for now, we are able to stay online for another couple of minutes, and we're here in case you got any questions. But thank you very much for coming. Again, sorry we ran out a bit late, but you got 5 minutes in your wallet, so next time we'll finish 5 to 11. Okay. Thank you.